I mentioned to Ashley, this sort of complements the talk I gave earlier to the Ugandans, which focused mostly on incontinence related to neurogenic bladder. So this is sort of non-neurogenic management of non-neurogenic urinary incontinence in men. So without further ado, we'll talk a little bit about the basics and then sort of focus a little bit on problems associated with filling, urge, and then problems associated with emptying, stress, and overflow a little bit. I know everybody on this call knows the anatomy, but just to review, the bladder, the prostate and the bladder neck complex is where the autonomic sphincter is. And then, of course, the voluntary sphincter is contained in the membranous urethra, just below the prostatic apex. And those are the two sphincters that are relevant in men. If we look at innervation of these structures, this first graphic is the storage reflexes. So storage is mainly mediated by sympathetic, the hypogastric nerve. And in the storage phase, the bladder outlet is contracted. Sympathetic nerves to the bladder outlet or the automatic sphincter are contracted, and the detrusor or the body of the bladder is inhibited. At the same time, the external sphincter is contracted, which is mediated by the pudendal nerve. Okay. At the time of voiding, a small reflex is sent from the bladder, afferent reflex from the bladder through the pelvic nerves into the spinal cord and up to a coordination center in the pons. The sympathetic inflow is shut off, so the bladder neck is relaxed. And then through parasympathetic pathway, the urethra it opens and the bladder contracts. At the same time, the nervous input through the pudendal nerve to the external sphincter is relaxed and the bladder empties. Okay. So male incontinence is common and it should be expected with aging. It's estimated about 10% of men over the age of 60 have incontinence, and it rises exponentially thereafter. As you see here, this is a community-based study of individuals in Sydney, Australia. And Emil, can you mute, please, honey?
Excuse me. Oh, excuse me, sir.
It's okay. And as you see here, among the males at 40 to 50, you're looking at a less than 5 to about 10% rate of leakage of urine associated mostly with urge incontinence. But then when you get up into the 75-year-old range, approximately 40% of community in a community-based population of men are reporting leakage associated with urge. So this is sort of a big overview. We keep coming back to this. I like this framework because it sort of really categorizes how I think about male incontinence. And always when we talk about incontinence, we break it down into failure to store and failure to empty, okay? So when we think about failure to store, we've talked about some of these. I talked about some of these in the other lecture, which you'll get the link for if you want to look at it, which are mostly neurologic sources. So we're going to focus pretty much on bladder instability or primary overactive bladder, also known as detrusor overactivity. And this is certainly the most common cause of leakage in men and women, particularly with aging. And a lot of systemic illnesses contributed to it, like aging, spinal disease, like spinal stenosis and lumbar disc disease, diabetes, radiation, and in men in particular, prolonged obstruction, as we see with BPH. So we'll touch on that at the end. Of course, any lesion in the central nervous system can also cause this, and we talked about that. That's sort of what we think about as classic neurogenic bladder. So we'll focus more on non-neurogenic sources here. This is just a brief overview of the evaluation of urinary incontinence in men, and I know everyone on this call knows how to do this. I think the most important thing to hear is that you can almost with 100% accuracy, at least with like 90% accuracy, know the causes and the risk factors and the likely types of incontinence that a man has with just a really good history, a urinalysis, and a good PVR. So you want to know when they're leaking, what kind of volumes they're leaking at, and how much they leak when they do leak. And then we always ask about obstructive symptoms, things like straining, slow stream, and irritative symptoms, which are more like frequency, urgency, small volume voids. Double voiding, where a man voids and leaves the bathroom and then returns to void afterward with a good amount. That's pretty classic for BPH, and so that's considered an obstructive symptom, even though some would think of it as more irritative. Pad use, if they're using pads, if there are differences between leakage at night and day, that can point to possibly a neurologic cause, or associated with stress effect, if patients don't leak at night, but they do when they're up and out of bed. Impact on quality of life, of course, is important because that determines how hard a patient's going to be willing to try to get control of their leakage. Medications, and we'll touch on that. And then, of course, drinking and voiding behaviors, in particular, drinking caffeine and alcohol. So overactive bladder or detrusor overactivity is a storage problem. It is a problem related to the bladder being hyperactive or spastic. And in man, probably the most common cause with aging is related to primary insult to the detrusor muscle itself. And that's usually bladder outlet obstruction in the form of BPH, of benign prostatic hyperplasia. It can also be in younger men, from urethral stricture disease, or like primary bladder neck obstruction. And we talked about that in this other talk that you'll get a link for. Intravesicular insults can also contribute to this, like caffeine, alcohol, medications, in particular diuretics, and uncontrolled blood glucose, where patients are spilling, causing glucosuria. Neurologic insults like diabetes, typically micro neurological insults like diabetes, or with respect to neurogenic bladder, we're talking about central nervous system etiologies, which I've already touched on. And finally, anything extrinsic that could be compromising the bladder can substantially increase OAB. So that would be most commonly constipation, but also pelvic tumor, or other considerations. This is pretty complicated graphic, but it's pretty easy to distill down. These are the AUA guidelines for treatment of non-neurogenic overactive bladder. And as we talked about, it starts with a good history of physical and urinalysis. And then the first line is always behavioral modification. After that, we go to pharmacologic treatments, and then finally to interventions. And we'll march through those one at a time. So the first line of treatment is behavioral modification. So always ask the patients how much caffeine they're consuming, whether they're using alcohol. I always start them off with a voiding diary so they can really quantify how much fluid they're taking in and what forms of fluid they're taking in and when they're voiding. The medications that are most problematic in my world, and they may not be in yours because I'm not sure how commonly diuretics or SGLT2 inhibitors for diabetes are, but diuretics typically used for management of hypertension, usually in the form of hydrochlorothiazide or Lasix here. And then the SGLT2 inhibitors are medications used for treatment of type 2 diabetes. They are relatively new on the scene, and there's a lot of them. And so the way I remember them is just they're all the diabetes drugs that have a Z in them. But these drugs work by taking sugar out of the blood and dumping them through the kidney. So they work by causing glucosuria, which can really, really impact a patient's overactive bladder symptoms, particularly if they already have some baseline OAB. Control their blood glucose. So if they are diabetics or they're borderline diabetics, get them to the primary care doctor so they can get that managed. And then, of course, constipation management is a big part of managing OAB. If those measures fail and the patients wish to proceed with second-line treatment, then the most common are the anticholinergics or antimuscarinics. There's about 8 or 9 drugs in this category available in the United States. And of course, you know, the decision to use, I base the decision based upon what the patient's insurance will cover and cost. Oxybutynin is the cheapest typically, and so that's often what I start with. They hit the M2 and the M3 receptors. There are M2 and M3 receptors in the bladder. And you can see where those receptors are located elsewhere in the body, and the side effects that they cause when they are activated. We have a drug available in the United States. I'm not sure if it's available in Kigali, called mirabegron. Myrbetriq is the trade name for it, and it works in a different way. It is a beta-3 agonist, and it's in what you can see here is instead of working as the anticholinergics do on the muscarinic receptors of the bladder, it causes active bladder relaxation. The real challenge that I have with this is that many patients cannot afford it and insurance won't cover it. In the United States, if they don't have insurance, it won't cover this. It's about $300 a month out of pocket, which is not affordable, but it does work quite well if patients can get it. There are a lot of contraindications to anticholinergics, and it's particularly problematic because these drugs are associated with progression of dementia, confusion, and falls. And we're talking about typically an older population. And so as patients get older, you get more and more worried about giving them these drugs. And also the side effects, it can narrow angle glaucoma, poorly controlled anginal symptoms or tachyarrhythmias, ileus or bowel problems, and myasthenia gravis are all contraindications. And of course, these tend to occur more commonly in older patients. In a man who has BPH, it's a relative contraindication. We'll talk about that because, of course, it weakens the bladder. And so if a patient already has a lot of obstructive symptoms and then you put them on this drug, they may have more retention. And the side effects are, you know, the classic anticholinergic side effects that we all know. Mirabegron is the other drug I talked about. And again, it's cost limiting. There are very few side effects to this drug, mostly hypertension. So if I get a patient on this and they have baseline hypertension, I have them checking their blood pressures at home to make sure that they don't have worsening of their blood pressure. There are really 3 interventions that constitute the third line of treatment for men with OAB and women with OAB. And I will tell you that 2 of them are much more tested and much more prevalent in a female population. And so I find that they are not as useful in men. The first is what we call posterior tibial nerve stimulation, or PTNS. And that's basically application of a TENS unit to the posterior tibial nerve. This is a picture just showing the setup. The patients come in and have these treatments, and they're done, you know, on a thrice weekly basis for a period of time, and then they go on to maintenance. And so it is pretty time intensive and resource intensive for a patient to come in and have this done. It's a very, very low risk. It doesn't hurt. There's some studies out there. There's one sham controlled study that I'd like to show. It's shown, the outcomes are shown here. This was using, they actually measured quite a few endpoints, but this is probably the most telling graphic in it. If you look at global response who moderately or markedly improved global response assessment scores, about half of them reported that. Now you can see among the sham, so there was a strong placebo effect, as there always is with this problem. So, but certainly the patients in the treatment arm had an improvement over the sham. that was significant. The real problem with this is practicality for patients who may be working or have transport issues, because it does require quite a bit of back and forth to the clinic. And to some extent, durability, it requires maintenance. And so I would say that probably more people that in my practice, I don't do this procedure, but my partners do. So if I have a patient that needs this, I usually send them over. This is sacral nerve stimulation. There are actually quite a few systems out on the market now. The first to market, I believe, was the InterStim, or the which is shown here. This is a picture of it. And it's put in phases. So the patients come in as an outpatient procedure, and they have a lead placed down in their sacral nerves. And then that's hooked up to an external device that sort of looks like a pager. And they work with the rep to find settings that are optimized. And if they have improvement of 50% of their symptoms after the test, then they actually have this little IPG, this little, wait, hold on, let me just move these. They have this little device here implanted into the fat pad of their buttock. And so the patients, once that's done, they don't have to return as they would for PTNS. The risks of this are different. Infection of the device is probably the most common, and when that happens, the whole thing needs to be removed. It's indicated for both overactive bladder, urgent incontinence, and frequency, but also for idiopathic retention, and it's been shown, much more promising among women with idiopathic retention. It is not indicated in patients who have obstruction, related retention. And so in patients, in men patients who avoid at much higher pressures and have prostates, it can be not that helpful in that manner. Botox is the last of them, Botox injections into the bladder. And there, to be fair, there's at least 3 drugs out there that can be injected. These are all different formulations of Botox, and they're dosed differently. I use onabotulinum toxin, which is the classic Botox by Allergan. And this is done in the office. It's shown here with a flexible scope, and in men, I always use a flexible scope with a small catheter that goes through the working port and has a needle that you deploy, and then you just inject in the bladder. I use this most commonly because I have such a large population of neurogenic patients, but it can work for patients with idiopathic retention. And there we go. And it's been shown to decrease urinary incontinence episodes somewhere between about around half of them. Incontinence can be achieved in somewhere between 1/3 to 3/4 of individuals who get this. It does increase functional bladder capacity by a decent amount, perceptible amount typically for patients. And the duration for idiopathic OAB is usually about every 6 to 9 months. In patients with neurogenic bladder, that duration is typically shortened, and they also tend to get higher dose. The main risks of this, besides having to come in to have the procedure done and sometimes some dysuria or hematuria associated with the injections, is UTIs, and then of course urinary retention. And urinary retention is a much higher risk in men, again, who get older and who have prostates that are obstructing, and they already have high pressure voiding. I like Botox because it doesn't have any systemic side effects. So if you have a patient, for example, with Parkinson's disease, or who may already have some baseline dementia, who absolutely cannot have anticholinergics, this drug doesn't have the concerns about falls and memory impairment. Next, we'll talk about leakage that's what we think of as sort of predominantly stress, and that's typically in men and patients who've had prior TURP or TURP-like procedures, or prostatectomy in the US population. This is a urodynamic profile showing a 67-year-old man who had a radical prostatectomy and was leaking 3 pads per day. And the image is not great, but what I can show you is, you can see here, as we do urodynamics, we have the patients perform Valsalvas and cough Okay, and you see here, there's no leak associated here, but the patients cough, 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 and then they have leak with Valsalva. And you could demonstrate stress incontinence as they perform these Valsalvas. You can't really see on the flow a blip because sometimes the blips are so small it doesn't make it into the funnel. But the nurses who perform these typically identify when the patients have small leaks associated with the stress maneuvers. So if you are performing urodynamics, I know last time I was there, you didn't have a urodynamic machine that was in working order, but when we do it, we always try to elicit stress incontinence in a patient who reports that clinically and or has a history consistent with a likely stress incontinence like TURP or prostatectomy. We all know that after prostatectomy, there's a lot of bad things that can happen, but incontinence is typically the most concerning and the most, maybe not the most prevalent, but it can be the most life-limiting. And then after prostatectomy, sometimes secondary things can happen that can worsen incontinence. So patients might be able to they might get dry, but then aging occurs, or they get Parkinson's, or they get some other insult to their spine or whatever. And then they have progression of their overactive bladder and leakage that occurs with it. Also, if they have, if their prostate cancer, if they require salvage or adjuvant radiation, that can destabilize the bladder and promote leakage, or if they're on androgen ablation, likewise. Also, sometimes, at least in our population, patients might have they may develop a bladder neck contracture that's not problematic for them. But that bladder neck contracture acts like a choke mechanism so that their sphincter doesn't have to hold back so much. And if they need any intervention, like say a kidney stone managed or a bladder stone or something like that, and a urologist has to go in and dilate up that bladder neck contracture or endoscopically incise it, then what can happen is that choke mechanism is sort of taken off, and patients can report worsening stress incontinence following those procedures. So I have a lot of patients that come to me and they say, well, I was just so fine until I had to go and have my kidney stone managed, and now I'm leaking 5 pads per day. It's not that the sphincter was even necessarily damaged. It's just that the bladder neck was may have been opened up to permit passage of endoscopic tools. The post-prostatectomy incontinence always starts with a good history and physical, and then we use sometimes urodynamics, typically in patients who may have other risk factors for an unstable bladder, like they've previously had radiation, or they have, really bad diabetes or something like that. Always check a post-void residual, because of course, if a patient has a large post-void residual, you've got to be thinking about bladder neck contracture as a contributing component, and you need to treat that prior. And then cystourethropy can help, and sometimes helps, particularly to evaluate the external sphincter, make sure there's not a bladder neck contracture. And because robotic prostatectomy is the most common type of prostatectomy in my population, these patients often have these little clips, which are called WEC clips, applied to the vessels for hemostasis at the time of prostatectomy. And those can migrate into the bladder at the anastomosis, and we often find them and have to remove them prior to treating their incontinence. So I always look in a patient's bladder before I treat them surgically, even if it's on the day of surgery. Technically, bulking agents are an option for treatment of post-prostatectomy incontinence. It doesn't work. If anything, it's just a temporary improvement, and so I never offer it to men. Slings and adjustable balloon devices are the next line, and artificial urinary sphincter is the third line, and the longest, the one for which we have the longest data. There are, just briefly, this is from the New England Journal Prostate Cancer Outcome Study. It's an old study, but I think it's really helpful to see how much leakage patients have at different periods of time following prostatectomy and radiotherapy. And you do see, as I showed you, that with aging out from prostatectomy, patients have worsened leakage. Not that surprising, knowing that all people have worsened leakage with aging. And then bother is pretty stable, but it does increase with aging. I use a transobturator sling, which is called the Advanced sling. It's made by Boston Scientific, and they do support some research that I do. It's best for patients that are really well selected. So patients with less than 3 pads per day of leakage and an ability to start and stop their stream so they have some sphincteric function, and patients with a reasonably stable bladder. It goes in, it's a very short procedure. It takes about, half an hour. Patients go home right away, and it's immediately effective. There are some post-op limitations for the patients. And while there's been a lot of talk about mesh erosion for slings placed in women, mesh erosion with this device is quite rare. I've only ever seen it twice. There's a lot of types of different slings and various different adjustable devices, some of which are FDA approved in this country, but many of which are not FDA approved. And so I don't have a lot of experience with some of these things, but I just wanted to show this. This is from a review from the ICS, the International Continence Society. And I think what you can see here is that the outcomes are just like all over the place. And I think that that's because when I think of all of these therapies, they really are best in men with really pretty mild incontinence. And if you don't select well, then you get pretty poor outcomes, or you just get temporary outcomes. And that's the other thing, is that we know that these, at least with the advanced sling, probably outcomes are durable to about 3 or 4 years, and then they do start to diminish with time for most patients. Poor candidates for sling include those who have had radiation, who have a severely unstable bladder, patients who have urinary incontinence while they're sleeping supine in bed, probably have more leakage than they're admitted to in the office. And most importantly, patients who've had a TURP don't do as well. And the reason why is because the way this sling works is by changing the relative location between the bladder, neck, and the urethra. And if the prostate's still there, as it is with a TURP, you can't get a lot of mobility of the urethra as you can following radical prostatectomy. I'm not going to show, but I have the link for a couple of animations that show you how both of these devices go in at the end of this talk, and feel free to click on it and take a look at it. They're from the company, and that sort of shows you the mechanism of action. This is the artificial urinary sphincter. It is the most tried and true of all of our treatments, and is best still for patients that have a moderate and severe leakage of urine. This device has been FDA approved since 1983 in this country, and it's the one for which we have the longest information. And what you see, this is sort of how it's placed, and we do some modifications if patients have had robotic prostatectomy or radiation as compared to open prostatectomy. But you can see here that this little cuff is placed through an incision in the perineum around the urethra. It's hooked up to a pump that we place in the scrotum, and then a reservoir that lives usually in the space of Retzius, but in men who've had robotic prostatectomy and the space of Retzius is obliterated, I put it underneath the rectus muscle on top of trans versalis. Anyway, in a resting state, this cuff is filled with saline. And when a man gets the urge to go, he goes to the bathroom, reaches up to his scrotum, like he's adjusting his testicle, squeezes this pump right here, which drives the fluid out of the cuff and up into the reservoir. And then it automatically refills over about 2 minutes or so. So a man doesn't have to reactivate the device after he's done voiding. He just deactivates it. We do this sometimes in patients who've had previous urethral reconstruction or have a really tenuous urethra. We can either do something called a transcorporeal, where we use a little bit of tissue from the corpora to sort of provide another layer in here. Or some people do what's called tandem cuffs, where you put 2 cuffs side by side. I don't typically do that, but we can talk about that more later or offline if you'd like more information on that. And again, there's a video and animation that shows you about this on the link at the end. The good thing about artificial sphincters is that the outcomes are much more predictable and reliable. I think you can see here that just glancing at these are sort of in the 80 range, and durability. These studies sort of run the gamut. Like there's one here that's a 30-year study that showed 73% efficacy. It's a small study, but you can see that that outcomes are pretty good and pretty durable in this, and that's been our experience too. The main risks, infection alone is quite rare, but infection associated with erosion of the cuff into the urethra, which most commonly occurs if a patient has a catheter placed in the urethra, that can be really problematic and somewhat catastrophic. Hold on, and then finally, I'm just going to talk a little bit about BPH associated leakage, which is most commonly, so this is sort of failure to empty, right? So BPH associated leakage can happen because of overflow. It can also happen because of overactive bladder, and I'll show you that in a little bit. This is sort of a classic urodynamic finding of a 62-year-old with straining to void, so predominantly obstructive voiding symptoms and UTIs, again, indicative of incomplete emptying. And what you see here is at the time of voiding, at permit to void, you see this massive bump in his detrusor pressure up to this is 100 millimeters of mercury of pressure. That is consistent with severe obstruction. And what you see down here is a very flat, this is the flow curve. And what you want to see is a flow curve that sort of looks like a nice bell. And you see this very flat, prolonged bell curve, again, consistent with high pressure, low flow voiding. BPH is, again, the most common etiology in leakage in men. So I just want to review what happens as a prostate becomes enlarged and or a man, gets metabolic syndrome associated with aging. It's thought that constant pressure or distension on the bladder causes bladder ischemia and oxidative stress, which drives a process of progressive overactivity. So it's really common in men who have a BPH, at least early on, that they have they have overactive bladder symptoms. Okay, so it's sort of a storage problem. And then with progression of time in obstruction, you see the bladder gets progressively stronger, and then after a while, it gets progressively weaker until the bladder basically can become atonic or severely hypotonic. And then we get into this stage of detrusor underactivity, where no matter what you do to the prostate, the bladder is still not going to be able to push to empty. And the big challenge in these patients is patients who may have a fair amount of instability, overactivity, either associated from other problems they have, like spinal stenosis or diabetes, but also from prolonged obstruction. And then you do a prostate reduction procedure like a TURP, and then these patients have a really spastic bladder, but not as much obstruction to prevent leakage. And you've resected their bladder neck, which is, of course, where their autonomic sphincter is located. And then they have leakage that is stress related. And that's the trickiest patient to evaluate with BPH. This is actually from the old BPH guidelines, but I like it because it sort of brings everything together. And it sort of drives treatment by the AUA symptom score guide, how to drive patients. But these are the indications really still to push someone to have surgery with prostate reduction versus medical therapy. And that's would be, if they had retention that was refractory to medications, persistent gross hematuria, bladder stones, recurrent UTIs despite medical therapy, or renal insufficiency associated with retention or intolerance of the medications. This is the IPSS, which I suspect you've seen before. It's used pretty universally, and it's a pretty quick way to assess both obstructive urinary symptoms and irritative urinary symptoms. And then there's a global quality of life score. And this should be used in driving decisions about how to treat men with BPH. There's a bunch of drugs that we use. I don't know which ones you guys use over there for BPH, but they're generally divided into the alpha blockers or the alpha reductase inhibitors. The alpha blockers started off with pretty non-specific types like Hitrin, which requires titration, or Cardura. These aren't really used in our population anymore, but they still are really good. And so patients that are on these drugs and have been on them, I just leave them on them if they're satisfied with them, because they cost almost nothing. Flomax and Uracetrol, or alfuzosin and tamsulosin, they are generic. They're generically available now. I believe Isolodocin is as well. I'm not sure about that though. And these are pretty selective for the prostate, but you still see patients that you put on tamsulosin and they have intolerance of it and are passing out or falling down or have really symptomatic orthostatic symptoms. That's really the most common intolerance. The alpha reductase inhibitors work by preventing conversion of testosterone to DHT in the prostate. And so they work by actually, instead of just relaxing the bladder neck as the alpha blockers do, by actually shrinking and devascularizing the prostate. And so they have a more prolonged onset of time, but better effect over time. And the biggest side effects to those tend to be sexual side effects associated with a lack of interest in sex and erectile dysfunction. Finasteride is available generically, and it's very, very cheap. Probably both drugs together are better than monotherapy. And so patients are really in trouble, I usually start them on both, and then I try to wean them off the alpha blocker after 6 months and see if they can tolerate it, because after 6 months, the 5-ARI is typically, at its maximal effect. So the big question arises is, if a patient has BPH and they also have overactive bladder, how safe is it to treat them for their overactive bladder if they already are carrying a little bit of residual? And that's there's not a great answer to that question, but if their PVR is 40% or less of their max capacity, and they've never had acute urinary retention, and their bowels are pretty well controlled, I think it's safe to add on an anticholinergic to their BPH treatment. So you usually get them started on Flomax or similar, and then you can give a trial of a low dose anticholinergic. There's a lot of cautions with alpha blockers. I'm sure that you all know this. They predominantly relate to patients that have wide swings in their blood pressure, or they have flash pulmonary edema or severe cerebral vascular disease or peripheral vascular disease. If patients are also on PDE5 inhibitors like Viagra, or they're taking other blood pressure medications, I usually tell them to take their alpha blocker separate from those. So if they're taking their blood pressure medications at night, I usually tell them to take their Flomax in the morning, or vice versa. And then there's this thing called floppy iris syndrome, which is mainly associated with patients who are given cataract surgery, and they cannot be on the drugs for that. The ARIs are the most effective of all the drugs, and this is the PLUS study, which I just referred to because it's pretty well known. There were over 3,000 men in this study that looked at placebo versus finasteride over a long duration, 4 years, and they saw symptom score, AUS, the IPSS score decreases by 2 points compared with placebo over that duration, and over a 50% relative risk reduction in acute urinary retention events or need for surgery. So they do probably, and the 5-ARIs have evidence that they can prevent a patient from progressing to need for prostate reduction surgery. That's becoming less and less relevant here because we have more and more therapies for prostate reduction surgery that are less morbid, and I'll go through those. And again, we sort of talked about this, but what do you do with the guy who, has unstable bladder? As you can see here, he's got some phasic detrusor overactivity with filling, and then at permission to void, which is right here, you can see he mounts pressure and can empty. But if you treat this with anticholinergic, how much are you gonna make him worse? Are you gonna put him in retention and flatten his flow curve? And that's a pretty tricky road to hoe. I'm not going to go through these. These are just some studies that look at that exact question. You can refer back to them if you want. And then I just want to share one thing, because a lot of people, and myself included, thought, okay, well, if a patient had a retention event and had a catheter placed and there were 2 liters in there, and then has a catheter for a month thereafter, there's no chance he'll ever be able to void again. Like, his bladder's probably dead. And I got some records from a patient. He was actually a dentist or an orthodontist, and he was supposed to come and see me. And I reviewed his records, and he was 65 years old. He'd had bilateral hydronephrosis with parenchymal loss, and was found to have a creatinine of 6.9. Had a catheter placed and was in retention for 2 liters, and then basically was started on ISC thereafter. And I think most people would look at that story and say, well, there's no chance he would ever be able to start to void again with a TURP. And certainly I called him actually the night before he came, because I figured he was probably canceling his own work that day, and said, he was traveling from afar, saying, I doubt that we're going to be able to get you off of intermittent catheterization. I reviewed the urodynamics that were done a year and a half ago, and it looked like your bladder wasn't working. But he said, I want to come and I want to try. And so we did urodynamics the next day. And what you see here for this individual is his bladder filled, and to a pretty high capacity. So this is about 800 cc's down here. But when he was permitted to void, you see him pop up very high pressure. His bladder actually was working. And this patient ultimately, he wasn't able to empty, but his bladder was working, and he was cathed for over 1,000 cc's. And we did do a pretty aggressive TURP on him, and he ultimately was able to void, and his creatinine remained stable after that procedure. These are the current AOA guidelines for surgical treatment of enlarged prostate, and it mainly goes by the size of the prostate. I suspect that prostatectomy and TURP are the most common ones done there. Now here we have some office-based procedures that involve called urolift, that involve like pulling the prostate back with these like little tacks that are placed in the office. Or injection of steam into the prostate, or aqua ablation. A lot of office-based procedures that can sort of evaporate or fulgurate the prostate in an office. And then there's a bunch of laser type of procedures that are done in the operating room, where lasers are used to either enucleate or fulgurate the prostate. And those are usually done as outpatient procedures. And really the difference between these is whether the bladder neck can be preserved or not, and how much tissue is ablated and that sort of thing, bleeding risk. And so the big drivers of this here is sort of what the patient wants, what comorbidities the patients have, and what sort of skill set the surgeon has, because there are just so many different types of treatments on the market now. I would say HOLEP is probably the leader in this space, and that is holmium laser enucleation of the prostate, where they go in and sort of core out the chunks of prostate and then remove them. I don't do that procedure. I have partners that do that. So just sort of taking it together, you can see here, for patients with bladder stability, we always start with behavioral modification, trial of anticholinergics if they can tolerate it, and then the treatments. For patients with TURP, we always evaluate them for sure with a cysto plus or minus urodynamics, and then we think about sling or sphincter. And then patients with BPH associated leakage, we sort of think about treatment of the BPH and then proceed to surgery with caution, particularly if the patients have overactive bladder. And then these other things I talk about in the other lecture, which you'll get sent. So just to conclude, all male incontinence can be treated, but it might entail a little bit of trial and error. And you should always start with the easiest option first, like medical treatment, behavioral modifications, before proceeding to surgical therapies, of course, especially if the picture is mixed, which it most often is for older men. I think with that, and then this is the animations, and you'll get this. We'll send this to you after the fact. So if you'd like to look them over, you're more than welcome to. So without further ado, I'd like to first of all, I'd love everybody, if you can, to turn on your cameras, because I'd love to see you all. I miss you. And if anybody has any questions, please feel free. Anybody? Is somebody talking and still muted?
Yes. Let me first of all say thank you very much for your lecture, which is very clear, straight to the point, and touching on everything. I'm sure there are many questions from my colleagues. Let them first talk, then I have one or two questions afterwards.
Hi, Alex.
Hello. Do you have questions, colleagues?
You're muted, Alex.
Well, what they are thinking, let me ask you one or two things. For those patients that with BPH that are candidates for, let's say, TRP, when do you decide to carry out your dynamic studies? What are the the factors?
Yeah. So current guidelines do not mandate urodynamics for patients with BPH symptoms, but I typically use them in patients who have a lot of instability type symptoms or have risk factors for having a really unstable bladder or a neurogenic bladder. And so, or if they have like Parkinsonian syndrome or some sort of neurologic compromise that would make me wonder, like, is this the right thing, right? So if a patient has a really unstable bladder, they have a lot of urgency, frequency, and then you TURP them, you can actually convert them from having dry OAB to wet OAB. And a lot of men would prefer to be urinating, fairly frequently and dry than leaking and urinating with less frequency. And so if a patient I think is at risk for that, I will for sure do urodynamics, and then I'll have a very close conversation with them about, okay, well, you may have more leakage after this associated with urge, and we may need to put you on a medication. So that's usually the criteria I use.
Mm-hmm. Now, once you get urine incontinence after TRP, let's say, for example, let me talk about a patient that I remember, 75 years old male, otherwise healthy apart from well-controlled hypertension. He's also diabetic, but quite well controlled. The blood sugar is well controlled as well. So he comes in with high PVR. So we do a TRP. The prostate was rather large. We just created the large tunnel for the patient to be able to empty. So what happened? Just, very severe incontinence. We try all kinds of things, physiotherapy, anticholinergics, didn't work, and eventually we do Botox, inject Botox, because he gets a retention of urine, but eventually stabilizes. What do you think is really what's happening with those patients?
Yeah, I think it sort of matters whether if they're leaking it sort of, well, first of all, if the patients are emptying to completion after their TERP, then you're in a much better situation than if they're still incompletely emptying. So if they're emptying to completion, but they're leaking, then they're probably having stress incontinence, which may be mixed. There may be some instability there as well. And in our situation, in my situation, I would put an artificial sphincter in that patient because they're probably leaking from stress, predominantly stress related. You may have to add an anticholinergic, but that's where urodynamics really would help, right? It would help distinguish, like, is this patient leaking because he just has a really, really unstable bladder, but his outlet's working okay, or at least his sphincter is working okay. Versus if it's pure stress, then we treat that with sphincter, with an artificial sphincter. And that can be that's the patient that's the most difficult. And obviously you want to make that decision before you TERP a patient, because a lot of men would prefer to, some men would even prefer to do self-catheterization to be wet. At least in our population, I don't know if they would.
Great. So another question. Of course, artificial sphincter here is problematic because of the costs.
Yeah.
So we're looking at other options. Even the slings, the ones you use in the US are quite costly, not really affordable to most people here. Do you have an experience of, the use of fasciolata or rectus fascia slings? Do you have experience of that?
So just not in men, in the perineum. So I will do fascial bladder neck wraps in patients with neurogenic bladder who have open bladder necks. And then, well, I haven't done one in a long time, but like for female patients that have had problems, for example, with urethral erosion from mesh or a diverticulum or something like that, we typically don't put mesh in those individuals. We typically use either fasciolata or rectus fascia. So those are the indications that we would use it for that, but I have not used it in a man for stress incontinence, except, in men like with spina bifida or spinal cord injury where I'm doing a bladder neck wrap. And that like 360-degree wrap is I know that at least a lot of the Egyptian surgeons are using that. I suspect a lot of people in pediatric urology, particularly in places where mesh is not widely available, are using that. Yeah, it's very unfortunate because I feel like the risks of doing a procedure like a TERP on a man and making him have stress incontinence are substantially higher in a place where you can't place an artificial sphincter, because obviously men are quite unhappy with that outcome.
Fortunately, we have not had really many, but even one simple case is case is a problem.
Right.
So another one is about when you come back, one of the things we are going to ask you is to help with urodynamics training.
Okay. Is your machine up and running?
Yeah, we have an old, there is an old machine at King Faisal Hospital, but in the Rwanda Military Hospital, they just bought a machine. I don't know which one.
Okay.
But they have. But I think that would be very great, to.
Good. And I'm going to send I have a little video link of our head of urodynamics nursing, of her setting up the thing. I'm going to send it to, through with all of this stuff. If you guys want to look at that, it's not very instructional because it's sort of really brief, but I'll send that also so that you guys can take a look at that. But I hope that I get to come back soon. I'm really excited to see you all.
So we would be happy to see you too.
Anybody else have any questions?
Anybody else?
Yes, thank you. I do have a question. Okay, thank you. So thank you for the presentation. So I have one patient that I want to present to you for maybe to help me how can manage that patient. I have one 87-year-old male, 87-year-old male, who came to me 20 years after radical prostatectomy for prostate cancer. He came because he had a recent onset of nocturia every 30 minutes. He can go like more than 10 times a night, but he's a bit stable during the day. Like he could wait for me 2 hours without going to urinate. So when we did the whole checkup, we found that he had also biochemical recurrence with a PSA which was rising up to 8 nanogram per deciliter, and we agreed in the tumor board that we start him on androgen deprivation therapy due to his age. However, his voiding pattern didn't change much. So we did, of course, we tried to see with PVR, which was 15 milliliter. So he emptied to compression, but during the night it is very bad. But during the day he's fine. He has no UTI. He doesn't strain to urinate. We tried anticholinergic without effect. Without response, really. He says there's nothing, no response.
Yeah, I definitely have him start with avoiding diary, Alex, and I can send one to you. Let me just make a note to do that. With avoiding diary, to make sure to see what he's drinking before dinner, make sure he's not consuming alcohol, etc. And then, isolated nocturia is usually related to, at least in my population, it's either related to nocturnal glucosuria. So if he's maybe eating a large meal at night and then his blood glucose is going up to 250, and then he's starting to dump all that urine into his bladder because he's pulling the sugar out, or uncontrolled sleep apnea. When you have uncontrolled sleep apnea, the peripheral BNP goes up and that acts like caffeine. So I would definitely have him measure it and see if he's making inappropriate amounts of urine at night. So at night, if someone sleeps 8 hours, they should concentrate. In those 8 hours, they should only make less than 25% of their total urine output for the 24-hour period. So if he's making too much urine at night, he's polyuric, then that's a medical problem. Okay. And those patients, you got to hunt down whether they need to be they need to be wearing a mask at night, or they need to get better glucose control. Is he a diabetic, Alex? You're muted.
Yes, sorry. He's diabetic, but very controlled.
Okay.
On anti-diabetic.
Yeah, even some that have like pretty good A1Cs, like their A1C is like 6.5 or 7. What you find is like during the day they may be well controlled, but if they eat a big meal at night, particularly if they're like nighttime, sugar eaters, they can sometimes bump up. So I would definitely have him fill out avoiding diary and start with that, and then calculate it all. You have to look at how much urine he's taking in and putting out. Other than that, there isn't like a great urologic explanation for having nocturnal frequency. There really isn't. it's usually a medical problem.
Yeah.
And then the other thing is once you get all that stuff tightened up, I usually put them on. Do you have oxybutynin IR?
What's that?
Do you have oxybutynin IR? Do you have immediate release?
We do. We do, but he didn't respond.
And what dose did you give him though, Alex?
So we have it oxybutynin on the name of D-Tropper.
Yeah, it usually comes in 5, right? 5 milligrams.
Yeah, I tried the 5 milligram and once a day, and then later he tried 2 times a day.
Yeah.
But he said there's no response. Yeah.
So these guys, sometimes you have to give them like 20 milligrams at bedtime. Just at bedtime, you give them like you give them immediate release at bedtime, and it just calms their bladder down at bedtime. And then it's worn off by the morning, so they don't have daytime, confusion and somnolence and stuff. The only other thing that is urologic is, and I challenge everybody when you wake up in the morning to try to make a fist, okay? When we go to sleep at night, our muscles also go to sleep, and the bladder does the same. So some men with obstruction, and he may have a bladder neck contracture if you haven't scoped him, even if his PVR is not bad during the day. And at nighttime, if his bladder is really weak, he may not be emptying all the way to completion. So Alex, if he's only emptying, he's getting up every 15 minutes, he's emptying, 40 cc's, and then he fills back up, that could be a piece of it. So I just make sure he doesn't have a bladder neck contracture, because his bladder may be very much weaker at nighttime than it is during the day when he's upright, and he can use his Valsalva assistance, and he may have better voiding efficiency.
Yeah. Yeah, thank you.
Sure.
Let me try that.
Okay. All right. Well, I know it's the end of your day, but it's the beginning of mine, so I got to rush off to clinic. It was really fabulous seeing all of you, and I can't wait to see you all in person soon.
Thank you so much, Dr. Wood, and thank you, Emil, for helping coordinate.
I'm going to get some things too to send out, so just wait before you send out the links, because I want to send like a copy of a voiding diary and some other things so that everybody can get them. Okay.
Sounds great.
Okay.